Hi, my name is Alex Kurtzner. I'm a fourth year medical student at Albert Einstein College of Medicine and a History of Medicine PhD student at UCLA. Today I'll be presenting an abstract from a historical article that I've written on a 1934 polio epidemic in Los Angeles County. This epidemic infected 2,129 people and was one of Los Angeles County's largest polio epidemics. After describing what polio is, I'm going to discuss how polio became a public health problem and stress Los Angeles' welfare institutions' ability to care for residents who contracted the disease. This story provides a lesson to consider how inequities detrimentally affect vulnerable populations' health during crises such as the polio epidemics and the recent COVID-19 pandemic. Poliomyelitis is a contagious disease that is transmitted when a person who is uninfected encounters a carrier of the virus. It enters the body through the mouth and multiplies in the gastrointestinal tract. Usually, the virus is destroyed by antibodies shortly after a person is infected. However, in less than 3 to 4% of infections, the virus jumps into the central nervous system and destroys the motor neurons that trigger movement, causing paralysis. This process is accompanied by fever and terrible muscle pain. When the virus damages the motor neurons of the anterior horn cells, it affects the parts of the spinal cord that are responsible for moving the arms and the legs. If the poliovirus invades the brainstem, it causes difficulty breathing and swallowing. If polio compromised breathing, it was often fatal before the invention of the iron lung respirator in 1928. The poliovirus was present in communities throughout written history, but the disease was relatively uncommon. Most newly born infants were exposed to the virus and developed a lasting immunity. With 19th century improvements in sanitation, children were no longer infected with polio at an early age and did not produce antibodies. When exposed to the poliovirus in an older age, there was a greater chance that it would cause paralysis. When the poliovirus was introduced into a community, older children, adolescents, and adults became infected, and paralysis occurred in significant numbers. During the late 19th century, polio epidemics were first reported in Europe and in the United States, and epidemics grew more severe after the turn of the century. Polio appeared during a time in which aspects of the contemporary disease control operations were put into effect. During the 1890s, with a new bacteriological understanding of illness, civic leaders had an arsenal of weapons that they could use to defend their cities against microbes, utilizing measures such as diagnostic laboratories and quarantines and hospitals. City governments soon had entire divisions, each dedicated to tasks such as handling contagious diseases and food inspection. The fact that the polio epidemics predominantly affected children gave the public health challenge a unique cultural meaning, and it was the impetus for the development of lasting welfare institutions. Since the United States was founded, the federal government had a limited role in providing social welfare to the population. The colonists brought to the New World the contemporary British model, in which local authorities provided public assistance. During the first 3 decades, the federal government passed important national programs which tended to focus on helping American families, such as the Shepherd-Towner Maternal and Child Welfare Program, which was directed by the Children's Bureau during the 1920s, or the military social insurance and rehabilitation programs for World War I veterans, which ensured that injured soldiers could enter the workforce and support their families. Because polio affected children, who were an integral part of the family, it is not surprising that the polio epidemics led to lasting welfare programs for children. For example, to help families pay for medical care following California's 1928 polio epidemic, Rotary Club members worked with officials to implement the Crippled Children's Service, which became incorporated in the Children's Bureau's Federal State Assistance Program for Children with Disabilities following the enactment of Title V of the Social Security Act. California Children's Services, which is the state's Title V program today, helps families manage the expenses of rehabilitating ongoing pediatric conditions such as cerebral palsy. Individuals who contracted polio but did not qualify for assistance through the national or state programs and nonetheless could not afford their rehabilitation care depended upon local authorities for public assistance. However, in Los Angeles and throughout much of the United States, local authorities were very stringent in their determination of eligibility and only approved care for persons with disabilities whom they thought could become employable after rehabilitation. Officials viewed patients with more severe forms of paralysis as infeasible and thus refused to invest resources in their rehabilitation. Officials often refused to fund rehabilitation also for women and for racial and ethnic minorities. For instance, in the 17 states with the largest African American populations, 91% of rehabilitation clients were young white men. Pervasive racial discrimination also limited non-whites' access to long-term care facilities. Finally, the United States at the time lacked national disability insurance for workers, unlike other nations like Germany. Workers who became paralyzed, whether from a workplace accident or from a disease like polio, thus had to depend upon local authorities for assistance. When Los Angeles' largest polio epidemic appeared in 1934, it would stress the fragmented local welfare system that was in place. As we will see, Los Angeles County's experience would present a microcosm of these broader welfare problems experienced throughout the United States during this time. Officials began anticipating the 1934 epidemic at the beginning of May when they noticed an increase in the case numbers over the previous year. County quarantined cases at County Hospital and began appropriating funds towards making serum from polio patients' blood in the hope that the treatment could forestall any further damage inflicted by the epidemic. The monthly total of cases in May was 155, and by mid-June, the epidemic had already infected 407 people for the month. As the cumulative number of polio patients increased, the county recruited nurses to address their shortage in personnel. However, with 50 admissions per day, county hospitals still lacked sufficient staff, and nurses worked 10 to 18-hour days in crowded rooms. Inevitably, their close quarters and their fatigue led to increased transmission, and 200 physicians, nurses, and other staff members contracted polio and were the sickest of county hospital patients. Observers noted that the interns, nurses, and attendants were terrified, and nurses commented on harrowing experiences they had working. One nurse, for example, recalled the horrible experience of having to prepare an iron lung for a colleague who suddenly lost the ability to breathe. Peaking in June, the polio incidence in Los Angeles County slowly declined. By August, the county had to deal with its inability to provide appropriate medical care to large numbers of patients disabled by polio. County officials established orthopedic clinics in areas with the highest polio incidence and relaxed stringent welfare restrictions to maximize access to medical treatment. The clinics served 600 patients, 400 of whom were noted by officials to have made complete recovery. In the years to come, the county struggled to meet the needs of the polio patients, however, who did not recover. According to the records from the time, 8 out of 10 county employees were unable to work following the epidemic. Facing poverty with no assurance that the county would support her, one nurse subsequently committed suicide. African American nurses who contracted polio also faced uncertainty over whether they would be able to access necessary medical care following being discharged from the communicable disease ward. The county reported difficulty finding long-term facilities in Los Angeles that would accept Black patients. In addition, all of the nurses had limited access to rehabilitation, and the California Nurses Association mobilized and demanded that services be made available to them. In the years following the epidemic, the nurses and their family members also directed considerable outrage at the county for its unwillingness to fully compensate them for their financial losses after they contracted polio. Nurses recalled depending on family and friends, and some resuming work despite still wearing back and leg braces. In 1939, one of the nurses who contracted polio used a March of Dimes fundraising campaign to educate the public about the situation that she and her fellow nurses faced 5 years after the epidemic. She wrote a letter that called attention to the heroism of essential workers. Perhaps referencing the national system of social insurance and medical care for World War I veterans, she argued that the nurses too were entitled to full compensation, writing, "Don't you believe that these nurses are as brave as any soldier who fought in the battlefield of France? I believe we were fighting for a more justifiable cause." It took a global pandemic to re-highlight the gross inequities that we live with and their impact on the underserved groups of society. Importantly, the pandemic also revealed the lack of protections for essential workers, many of whom are from socioeconomically disadvantaged communities. We are now at a time in which most Americans support expansive federal measures, such as President Biden's stimulus bill, to help families who are struggling during the pandemic. During this time of openness to change, this story presents a lesson to prioritize our nation's essential workers' needs and to be aware of others whose needs are currently unmet in meeting the challenge of advocating for a more responsive system.